Thank you. So we're going to continue, and we'll talk about general practice with the subject private practitioners or businesses. Jean-François Charles and Jacques-Olivier Dauberton, would you like to come up to the stage? We've got some time to spend together. Jean-François Charles, you're a general practitioner, so you're in Montargis, and you went to England because you were fed up and you started work for the National Health Service. The mythical system that the English love, it's an ultra-liberal system, but there's contradiction everywhere. Then you stopped. And now you're a general practitioner in London. So when you're in the NHS, how is it organized, for your consultations? Thank you for your invitation. Please speak close to the microphone. Usually, I'm used to a face-to-face, more of a conference rather than a face-to-face debate like this. Why did I leave France, first of all? Well, because I'd reached a burnout situation. There was kind of a problem of self-harassment. So I was stressed. So I joined the NHS in 2002. It was recruiting doctors, and as at the time in France we were trying to recruit Spanish nurses to offset the lack of nurses in France. They were very hospitable. We had training, we had English lessons, we had actors who were pretending to be patients so that we could practice. So how long did that last? 12 weeks. And at the end of this course that was paid for, then we were allowed to go back to the other side of the channel if we wanted or not. Anyway, I joined the NHS as a salaried employee. After being a private practitioner in France, a liberal private practitioner in France, I was happy about it. I had a wage, however many patients I saw. If the secretary was ill, then somebody replaced her. But the problem is that after a certain while, there were guidelines that were rather restrictive that came out that had to be complied with. My English colleagues let me understand that my behavior was not kind of standard behavior when it came to following the guidelines. For example, there was one case of mononucleosis where I diagnosed it during the first visit, and I asked for a blood test to be carried out. And the staff next week asked me why I'd asked for a blood test. Well, I said, well, he's obviously got infectious mononucleosis. Normally, you're supposed to see him on the third day, and it's only on the third day that you ask for a blood test. Anyway, so at the same time, I had to raise my hand, put my hand up like in a classroom to ask when I could go on holiday. So I realized that there was a population of patients in the private sector who were requiring healthcare, and so now I'm just involved in private practice again. So when you arrived, how long did you have a consultation? It was 6 minutes. When we were training, but it was every 5 minutes in reality. And if you were late, what happened to the extra time? Well, the secretaries manage the schedules. When you consult with the NHS, you mustn't forget that it's a context. We live in a context with great healthcare systems. It's not Africa, we're in Europe. So the secretaries manage the appointments, and they give you, for example, because you don't have to say why you're coming to see the doctor afterwards. You're given an appointment for next Tuesday at 1 o'clock, 1:21. So you mustn't arrive at 1:25 because the consultations were managed every 7 minutes. Now, I believe there's a quality outcome framework. So there's an objective. The consultations can last 10 minutes. So the patient in the morning may have a longer consultation than the patient in the afternoon. That's just to increase the statistics. It's not allowed for in all healthcare centers. So now the objective is every 10 minutes, So if the patient arrives late, the secretary has to say, I'm sorry, but you go home and ring back for another appointment. And so you don't have to do anything administrative apart from stamps. Everything's managed by the nurses. Yes. Well, English doctors do a lot of administrative work, but it's more of voluntary work. They do activity audits. Every year, there's an appraisal. We audit activities, notably since there was a scandal with a general practitioner involved. It was terrible. It was 2004. He committed suicide in prison when it was discovered that he'd probably killed over 400 people. So the NHS, following this, had to undergo restructuring. And it was a terrible crisis. So doctors no longer work on their own. There's a kind of a self-control between doctors that is operated, and healthcare centres are grouped together. So remember, we talk about these maisons médicales in France, and this is so that there are no single-only centres, so they're grouped together these days to prevent this kind of thing from happening. I've lost my train of thought now. So basically, we were talking about administrative tasks. So there's a checkup. They check whether you're alcoholic, whether you're depressed, etc. Well, in relation to the audit, there is a certain amount of administrative work to be done, notably to prove that we've got at least 50 hours of professional training that has been validated on a yearly basis. And we have to think about our behavior. For example, what are our strong points? What are our weak points in terms of our behavior in front of patients? If patients complain or if patients compliment us, we look at our strong points and weak points in relation to the way we manage the administrative staff, and we talk about our personal project. And then the next year, in relation to the previous appraisal, we look at whether we've achieved some objectives or not. So it's something that takes place on a yearly basis, and the objective is to try and really identify non-ethical behavior. And so this is something that we find in companies. Human resources managers are very familiar with appraisals. You are part of a trust, no? How many doctors? These are big machines. There are hundreds of people in these trusts, no? Tell us about that. In the NHS, there are care trusts, so social security funds or national health funds that manage hospitals and manage a certain number of neighborhood centers. So that there are sometimes private practitioners because they can't fulfill all needs. The problem is that you can't choose your practitioner when you live in a certain neighborhood. You have to go to a certain health center. You have to go to the local dispensary. And if you move, even if it's by 2 streets, if your health card takes you beyond a certain border, you have to change your healthcare center. So it's a system. There's no notion of family doctors. In France, we have these family doctors. We can go to the doctor that we choose to go to, whereas in the English system, there's no notion of family doctors. It's the secretary, as I was saying, who manages all of the appointments. I think it's good for a patient to be able to see the same doctor for the same problem, even if things are noted down in the IT system. There are other things that are important that are not necessarily put into the IT system. Now, for our next speaker, we got to know each other at the Sénat, Mr. Jacques-Olivier Dauberton. Now, healthcare centres, they were good, these maisons de santé. We said that we needed a doctor in each village. We weren't convinced. You were the president. You've just left the presidents of the Union of Young Doctors, and you're happy. And it's great to see this, because when we hear general practitioners in France, it seems like we're in a crisis situation. And when you hear young people, it's different. So you're in Champagne. Yes, that's right, in Champagne, in a lovely village. It's called Saint-Rémy-en-Beaumont. It's the deep country, and I'm a young GP who's happy, who earns a good living. So let's say it that way. So everything is fine.
I was lucky enough to be able to create my own practice. When we're talking about entrepreneurial medicine or private practice, is the doctor and the healthcare team in a company? Do we have to create things? We need to innovate in the field. And I was lucky to meet with a healthcare team with nurses as an intern. So when I was interning in Reims, and I was able to meet these nurses, and we created a healthcare project together, and we worked with elected officials to create this healthcare center, the Maison de Santé. This is what I wanted to do, and the nurses also. So we're in this configuration now, and I'm actually happy to leave my house, to leave my kids, to go to work. I really enjoy it. So tell us a bit about the conditions. How many of there are you? I'm in a very deserted zone in terms of healthcare. The small village is 200 people, but in terms of patients, there are a lot. In terms of consultations, when I replaced the doctor before me, he lived in Corsica, and he would come on Mondays to Reims. He'd arrive at 7 in the morning. He'd work till midnight. He'd do that all week, nonstop. He did his on-call work, and then he would go to back to Corsica. He would be on call every second week. So when I started, I laid the groundwork. I'm a young father, and so I took my Wednesdays off to take care of my kids. Was that hard? Oh, the patients didn't understand. They said my wife was available to take care of the kids. I said, my wife wouldn't really appreciate that because she works too. So the nurses were also tired of going through all these patients at high speed, and so we put everything on the table. We talked about money, we talked about budgets, we talked about what kind of organization we wanted to set up. And in France, we're lucky to have what we call a liberal system, but it also causes problems because the liberal system is limited to the act, and when you want to share things with other healthcare professionals, that's a limitation. So we really had to figure out other ways of financing, to finance things that didn't necessarily exist on paper. So we took the time. It took roughly 3 years to come up with our healthcare project with the municipality, and we've almost completely succeeded. We've only been doing this for a year and a half, but for this year and a half, we've been improving things constantly. As a doctor and for the healthcare team, what I found complicated is I didn't know if I was doing quality work or not. I can see people for 15 minutes, half an hour for any type of pathology, complex ones and less complex one, but who says I'm practicing medicine properly? So we asked that question with the nurses. We decided to look at our data to see if we could have an impact. And that's where the French system is a bit paradoxical. We're rather limited. I'm going to be highly criticized for what I'm saying, is that the private practice talk about freedom that doesn't exist. In fact, we're paid for the ambulatory patient, and that limits things. And what's going on in the field is going more quickly than the laws and that govern medicine. There's telemedicine and other health tools, and the only people that can answer are the people in the field and meet the needs, and it's not the administrative structures that can do this. They're also stuck. Would you be in favor of having healthcare indicators be sent out to the patients regularly, so you get some automatic feedback that allows us to judge our results? So not just results on the medical condition, but on the social aspects, family aspects. I think the young generation is in favor of this because we have to work on a primary health team. We were talking about this morning. Where is the financing going to come from, though? We have to really ask about the financing for primary health care. What goes in there? What's fundamental? What has to be paid by the state? And what's paid from other resources? So a healthcare team couldn't talk about all these points, talk with the patient, say, why is there this extra billing? Why are we doing this? So in your organization, how would you like to be paid? Is it like at a Monop or a Carrefour, a medical structure? Yeah, it's open late in the evening, early in the morning, except Wednesdays, of course. But from the remuneration, would there be a global envelope and then you share it out? Would you have employees would partly paid by acts? How do you see things? Because either you're an employee or you're paid by the act. So now we have an envelope and people decide how they want to work, either as an employee or paid by the act. And I think we need to work on capitation. I think 82% of the GP's pay comes from the act and 18% from the fixed fees, and that's not compatible with the work that we do. We need to have more of this forfait or fixed fees. The teams have the maturity, they do it already. They have to be able to be responsible for people, and I think that they have the means to do this. If we create an act for one person, we won't be able to share this as a team. So would you think that the doctors should be able to communicate together? Yes, we've set up a coordinator, a social coordinator in our healthcare center. A lot of people come for social problems, so created this job. She manages this aspect, and so we went to the hospital to say we wanted to make the link between the coordinator and the hospital at Vitry next door. So to send the information on so that when we have social information about the patient, that we can be informed, we can organize the necessary visits so that everyone is aware of the problem so the patient's not discharged on a Friday night and left alone. And we talked to the director of the hospital, and there's work to be done on this point because they haven't understood why we're asking for this. The public hospital is already doing it, and we're saying, well, yes, but not really. We're doing part of it, so it would be good if we had the possibility of doing this, and we would like to talk to you. We would like to be able to send the medical information in secured channels. We want to have a link with the doctors directly to be able to discuss with them, and they're saying, no, you have to go through the nurses, the nurse level. There are different levels in the hospital, so there's still work to be done. So with the emergence of robotics and digital healthcare, medical specialties are going to suffer and change. This is true for biology and radiology because we can see 32 things when a computer could see 300. So what's going to be vital is the GP. He's going to become the bioconsultant that's going to bring into perspective everything that's said by the machines. And it's going to be difficult to sit in front of computers all day long. We want to see people face to face. And I think that the future is really in GP, and the specialists are really going to have to think about their demographics and their organization. In England, is this the same situation? Well, the fault of the British system, because the doctors have such short appointments, they don't really get to know the patients. Telemedicine for the radiologist can read an x-ray at the other end of the world, that's true, but let's not forget in our basic studies, we've always been told clinical examination, you have to examine a patient, you need to touch the patient. Yes, but some illnesses are mute and you need the chemistry and other analysis. We can't get rid of the physical examination. I think what was said in the previous debate is true. There's a barrier between the public hospital and the private practitioner, and it shouldn't exist. The example of the ER is typical. We reduce the number of people going into the ER. Even if I'm the only doctor, the nurses also have instructions, and we have ways of treating the patient. So the patients are not necessarily going to the ER, but they come to see us because we have certain times available to them. So you have to redefine everyone's role. I'm not sure if these are just habits, trade union habits, or sticking points. We're not communicating properly, and there's an opposition. The budgets are separate, everything is separate, and if there's a real revision of the global health, doctors, patients, the hospitals, everyone that's involved in the system, if we all talk together, we could make it move forward, but right now it's blocked. On the terrace, you you told me something I think it's worth raising here. We talk about telemedicine. We talk about face-to-face contact with a patient. You can also do this through Skype. We've talked a lot about prevention and how important it is. Since this morning, we've been talking about expenditures. It's like for energy savings, the main energy savings are the expenses that we don't incur. And I was surprised by the number of people who I saw on the terrace this morning still smoking. Thank you for all smiling about that. I think some of you are going to be unhappy if I ask these smokers if they've signed a document committing to when they get lung cancer or if they need a stent, it will not be the collectivity that pays for this. Is that the case in England? Yes, there are patients that were refused because they were continuing to smoke. It's pragmatism. It's efficiency. It's evidence-based medicine. The collectivity shouldn't pay for everything. We need to find efficiency. The expenses are going to go up in healthcare, that's true. And we need to find a way of ensuring that we're efficient, that all the players are efficient in the healthcare system, and we achieve good health for everyone, and that means everyone has to be responsible. I'd just like to add something. Earlier on, we talked about the pharmacists who could vaccinate. So let's go down into the field again. Don't forget that there are nurses that are also there to do that. Yes, we all agree. So two family doctors, that's the real great word. You deal with families from grandparents to the grandchildren, where they live. You know everybody. That's real medicine. Are you both happy in the work that you're doing today in England? Well, I didn't talk about my private practice right now. I work as though I was an architect or a landscaped architect on the same basis. So I don't have to report to anyone except for my colleagues, the Order of Doctors and the Council of Doctors. And I think one thing that we haven't talked about today is our medical code of practice. There are two very important elements. My wife isn't a doctor. She works with patients who have different pathologies, but she's not a doctor. I think we're happy doctors. We can't continue to talk about unhappy doctors who are being crushed by the administrative tasks. I think young doctors today can choose the job, the profession that we want to have today, and we need to have the ability to choose that with our teams. I think there are a lot of young doctors who are ready to be responsible for that, and we have to give them the possibility of doing it. And we want to be part of the negotiations on the medical conventions. Yes, burnout is a possibility, though. Yes, but it's corrected if we all work together and we can properly allocate the tasks. So I met two happy doctors. Wow, that's great. Thank you.